we'd like to move on to our next session. And for next session, our chairpersons include Dr. Chitranshu Vashisht, Dr. Deepak Gunjan, and I would request Dr. Amol Bapai to also please stay around. He's there with us, and we can invite our speakers for next session. Thank you, sir.
Okay, so Deepak and Chitranshu, good evening to you all. And would you like to invite, or I think I can see Moin and Amrita, both of them here. Maybe I will go ahead and invite Moin, and then one of you all can invite Amrita. So Professor Moin Kashyap is from John Hopkins, Baltimore, USA, and I must say I have the privilege of calling him my friend, a very good friend, and he is one of the most prolific writers as well as excellent technical skills in endoscopic ultrasound as well as interventions related to EUS as well as so many other advanced endoscopic procedures. So Moin today is going to talk to us about the EDGE procedure, or EUS guided transgastric ERCP, how I do it. So Moin, over to you for your excellent talk.
Thank you, Amol. Can you hear me?
Yeah, we can hear you. We can see your slides. We can see you. No worries. Good to go.
Okay. And can you see my slide?
Yeah.
Okay, excellent. Hi, everybody. Thank you, Amol, for the introduction. Good to see everyone. Hopefully, we see each other in person soon, but I'm glad to be here. Thank you for inviting me. And as Amol said, my talk is on the EDGE procedure, or EUS-directed transgastric ERCP, how I do it. I'll show you a couple of slides on data, and the rest will be videos focusing on the techniques and potential complications. This is an initial study we published a couple of years ago in gastrointestinal endoscopy in patients with Roux-en-Y gastric bypass needing ERCP, comparing enteroscopy ERCP, which is seen in this image here, where we go through the gastrojejunostomy, reach the jejunal anastomosis, then go to the afferent limb and retrogradely cannulate the pancreaticobiliary system, versus the EDGE procedure, where we create a gastrogastrostomy or a jejunogastrostomy, and then through the LAMS perform a standard ERCP. In this initial experience, these were our initial cases. This is a multi-center study, 30 versus 30 patients. You can see the technical success in the enteroscopy ERCP arm, 60% versus 100% in the EDGE procedure, and you save a lot of minutes, 90 minutes versus 50 minutes. So we'll show you some safety data, but here the adverse events were comparable in both. This is the most recent study we published just a few months ago in endoscopy on a very large group of patients, 178 patients who underwent EDGE procedure. You can see that the initial part of the procedure, placing the LAMS, was successful in 175. Then the ERCP was successful in 172. So in all comers, 172 out of 178 had a successful EDGE procedure. So the technical success is extremely high. We are all worried about persistent fistulas because and reversing the Roux-en-Y anatomy. Out of 90 patients in this study, so about half of the patients underwent objective testing, either with endoscopy or upper GI series, to look for a fistula. And the persistent fistula was found in 9 patients out of 90, so 10%, so not very high. And there was no difference if the fistula was a gastrogastric versus jejunogastric. We found that probably in diabetics, and importantly, in patients whose stents were left in place for a long time, the rate of fistula was higher. 5 of these 9 patients underwent endoscopic therapy of the fistula, typically with either suturing or over-the-scope clip, and all were successful. So this is just some data about what's out there with respect to technical success of the procedure and then the risk of fistula. So let's move to the technique, and I'll be showing you multiple videos. I'll let these videos play so that we can speak about the details, and hopefully more of you will perform this procedure. This is a patient who was admitted with abdominal pain, dilated bile duct, and evidence of stones in the bile duct on imaging. Patient has undergone cholecystectomy and Roux-en-Y gastric bypass. Here we access the excluded stomach with a 19-gauge needle. I do a test injection to make sure we're in the right place, and after we confirm we're in the excluded stomach, then I attach a pump with contrast and saline to the 19-gauge needle, followed by access of the excluded stomach with a 20-millimeter hot axius. We don't use a wire. As mentioned by Mark in the previous lecture, the wire tends to push in structures away from us. We try to avoid it. In the past, we used 15-millimeter lambs. Now, exclusively, we use a 20-millimeter lambs. As you will see in a minute, that allows procedures to be performed in one session without risk of migration. So I'm going to show you how we do this consistently. So we place a 20-millimeter lambs and then dilate with an 18 to 20-millimeter CRE. Here, as you see, it can push you in, it can suck you in. So you want to pull on the balloon. If you have the balloon inflated and you don't like the position, you don't want to manipulate it so that the stent does not migrate. Once the stent is fully inflated, then I like anchoring them. So there is a risk of migration. So risk of migration during the index procedure is equivalent to a perforation. So we don't want these stents to migrate. It can create a mess. So I like to suture them, and I place one suture on either side of the lambs. So we use the overstitch device. Of course, these days you can use the stent fix device from Ovesco. There is an increased cost with this strategy, but the main issue is avoiding the risk of migration and perforation and attempting to finish the entire procedure with in one session. So here I'm going to let this play so that you see the details of how we overcome some difficulties during the procedure. So we take one bite through the gastric or jejunal wall, one bite through the lambs, and then the last bite through the jejunal wall or gastric wall, and then cinch the lambs to the wall. We want to avoid over pulling on the lambs here and pulling it out of the gastric or the excluded stomach to the pouch. We need to avoid that. Also, we want to avoid pushing the overstitch device to within the lambs because it can anchor to it and cause problems. I haven't encountered that, but I can see that happening. Here, you can see the stitches on either side of the lambs. And once this is done, then we'll be ready for a standard ERCP using a standard duodenoscope and standard instruments. And we can perform all kinds of procedures as in patients with standard anatomy. So we can push the EUS scope, we can push the EGD scope or ERCP scope and do advanced ERCP procedures with lithotripsy, stenting, etc. So we can perform complex procedures such as in patients with normal anatomy. So let's go to another video. This is a patient who I did recently. a patient who presented with distended stomach, gastric outlet obstruction in the setting of Roux-en-Y gastric bypass due to a pancreatic mass in the Uncinate process. So the stomach here was already dilated. So here you see the stomach without injecting any fluid, 20 millimeter lambs, no wire, pulling the lambs, creating a gastric gastrostomy here. A lot of fluid came out. Again, this patient has gastric outlet obstruction due to a pancreatic mass. So here the idea is to drain the excluded stomach because the patient is pretty symptomatic, to access the excluded stomach and get an FNA of the mass, and also drain the bile duct because the patient is jaundiced. So all of this can be performed in one session in this complex anatomy with very complex patient presentation. So here, as you saw before, this is a gastric gastrostomy, 20 millimeter lambs, suturing on either side of the lambs with the overstitch device. So I consistently perform the procedure this way, and for the last 40 cases performing it in this manner, I've encountered 0 migrations. So we'll talk about fistulas and how to manage them and other complications in a little bit. Here I'm gonna let this play and suture on either side. And the idea with the 2 sutures is when you're pushing with an ERCP scope, you're putting some traction on that device, and basically to make the traction equivalent on both sides to keep it in place. This is we're now in excluded stomach, and we see the gastric outlet obstruction. So we treated the gastric outlet by draining the excluded stomach to the pouch. So that's treated. Here we performed an FNA of the mass, and now we're going through the lambs with an EOS scope, linear EOS scope. And here we're going to perform a choledochoduodenostomy. A little more difficult in the US to perform choledochoduodenostomy using lambs because we don't have the 6 and 8 millimeter lambs. Here I still decided to use the 10 millimeter. Of course, not easy, but doable. I don't like putting wire, especially with this duct that's not too dilated. It's just gonna push it away and make the procedure more difficult. Once we place these 10 millimeter lambs, because of the thick flange as compared to the 6 and 8, we should place a double pigtail through them because the posterior wall, when the duct collapses, can impinge on the internal flange and cause obstruction of the lambs. So we like to put a double pigtail here, just injecting some dye because the procedure was difficult. Here is a feel that the lambs was at the edge actually of the bile duct. It was good. The duct is more dilated than that. And then we place a double pigtail stent through it and make sure it doesn't get obstructed. So this is a patient, this is a very complex case where the lambs was left in place, the gastric lambs was left in place for a long time because the patient had pancreatic cancer. She had to go through chemotherapy, radiation therapy, Whipple. So the lambs was there for a long time, and the patient developed persistent fistula, and we sutured it, but that failed. So typically we use either an Ovesco or suturing. If that fails, this is the septal occluder that we use for ASDs and VSDs in the heart. This is the last resort, basically a plug to close these fistulas, and this is extremely effective. You just leave it there, and it causes tissue hyperplasia over the plug and works very well. This is an expensive device, but it works for these persistent fistulas. This is just to let you know that beyond suturing and Ovesco, if something happens, then this is your last resort. Here, this is similar to a lamb's, it's a lumenless. And here, after you place it, you turn that screw anti-clockwise to unscrew it, and then completely release it from the system. as you can see here, and you just leave it there. This patient did extremely well. We got an upper GI weeks later. This device is in place, caused complete occlusion. This is a last resort. So I'm gonna spend the last few minutes showing you some complications of the procedure and how to avoid them. It's a relatively long video, so I'm going to not play the entire video, but show you bits and pieces so that you can understand some complications. Sorry for that. So this is a patient who has a LAMS, and you can see here that there is the LAMS was tending to migrate into the excluded stomach. So this patient was having pain after LAMS placement, and I brought the patient back, and you can see that the large flange, the flange on these 20mm stents, I think it's 29mm. So you have a 3-centimeter flange within the wall itself. It causes a lot of pain. So if a patient complains about a lot of pain, take that seriously. These LAMS can tend to embed, like we've seen in the antrum. You know, when you place like a stent between the antrum and the gallbladder, this can happen. I haven't seen it much in these cases, but just take abdominal pain after these procedures seriously. This is another patient who also presented with anemia, GI bleeding, abdominal pain. So now remember, you have a gastrogastrostomy. So all this acid is coming from the excluded stomach to the pouch and pooling at the gastrojejunostomy anastomosis. And there's a risk of massive marginal ulcers. So it's a must to discharge these patients on double dose PPI. Ensure they are on double dose PPI until you confirm that the gastric fistula is closed. So you'll see here that look at these massive ulcers. So this patient was not taking the PPI and presented with significant symptoms. This can cause anemia, GI bleeding, abdominal pain, gastrojejunal strictures that are severe, and we've seen massive bleeding. So you have to be careful and place these patients on a double dose PPI. So other things that we see, this is a patient who, let me go back here, bleeding after dilation of the LAMS. So be careful when you are creating the anastomosis or puncturing the excluded stomach. Make sure there are no vessels in the region, not just in the pathway. You're dilating the stent to 20mm. These days, I actually like to dilate just to 18, because you know the stents we place through through the scope esophageal stent that is widely available is 18mm in diameter, so that it provides good tamponade. I dilate them just to 18. And here what we did is we tamponaded with a balloon for a few minutes, followed by placement of a through the scope esophageal stent. So this is something to do if this happens. And then a few weeks later, we removed the LAMS and the through the scope esophageal stent, and everything was good. Let's see what's this case here. This is a patient who actually you've seen before. This is the one I've used, the septal occluder. This is, so what happened here, we have a gastrogastric fistula, and then they did Whipple and they closed up the stomach. And there's a lot of retention of food in the stomach that's closed up right now. So what you want to do is communicate with your surgeon, and probably a surgical gastrojejunostomy is needed in these patients. Look at this massive amount of liquid and food that happened here. So what we did in this patient is, because there is no surgical gastrojejunostomy, we created an endoscopic gastrojejunostomy, actually jejunogastrostomy. So here we thought the easiest thing is to go to the efferent loop, and the stomach is dilated, full of liquid and food, and it's a huge structure. So instead of creating gastrojejunostomy, we created a jejunogastrostomy. So here, just beyond the gastrojejunostomy anastomosis, we punctured the excluded stomach, that's humongous, you see here, and placed a new LAMS to drain that stomach. Persistent fistulas. So we like to opacify, to ablate with the APC. and then either use suturing or Ovesco. Both work very well. I've had no patients up till now where I could not close these fistulae. The most difficult one is the one I showed you, and the end of the eventual outcome was excellent. So that's all I have. Thank you for your attention, and I'm happy to answer any questions.
Thank you, Dr. Moen, for your excellent talk, and you have given a great overview of edge procedure. However, we have exceeded the time. However, there are 2 questions in chat box by Dr. Manuel. You can answer there. And we can move on to the next talk with Dr. Amrita Sethi. We have heard from her previously also, and she is a therapeutic endoscopist and have a great interest in endoscopic ultrasound. Dr. Amrita, please.
Thank you. I'll just share my screen here. Great. Can you see that?
Well, Dr.
Perfect.
And we can hear you also.
Great. Thank you so much. Thanks to the course directors for inviting me. It's really an honor to be here with my friends virtually. And I just hats off to the organization. I had a chance to look at the website and the format, and it's really quite impressive. And it's a very impressive group that you formed here. So I'm going to talk to you today about tips and tricks of difficult EUS FNA. It's a very anecdotal talk, not very data driven, but we'll see what kind of tips we can give you. I'll just advance my screen here. So really the biggest challenges that we have with EUS and sampling are in really getting a good representative sample and dealing with issues of poor cellularity or really bloody aspirates or necrotic aspirates that don't give us good representative cells. We can have lesions that are difficult to access either because of their consistency or because of their location next to vessels or, for example, calcifications or just the angle related to the scope and the needle coming out. And we'll discuss a little bit about different strategies that can be taken to help with these challenges. So if we look at the accuracy of EUS FNA, it's actually quite good throughout the literature. Pancreatic lesions, about 80 to 85%, lymph nodes, 90%, cystic lesions, 60 to 70%. But in truth, these results really are quite variable across studies. And if one really looks at it, the accuracy has been largely unchanged in the last 15 years. There is some data to suggest that larger lesions, those greater than a centimeter, are associated with increased accuracy. And therefore, I think in general, we tend not to sample lesions that are small, particularly lymph nodes, because of the difficulty in obtaining adequate tissue. So if we start to think about what are the different factors involved and how can we help with the situations in which we're not able to get good amount of tissue, the first thing to ask is, what about the size of the needle? And here we're discussing 19 versus 22 versus 25 gauge. In truth, one might think that bigger is better, but that's not necessarily the case. And if you look at the literature again, there's not really no conclusive data that FNA needle size affects the sensitivity or the accuracy. What we do see is that smaller needles are more flexible and they're easier to maneuver and therefore might be better. For example, 25 gauge needle might be a better needle to choose when trying to sample the uncinate process or situations in which there's a lot of scope angulation and or torque required in order to visualize the lesion. Larger needles, such as 19 gauge needles, can be much stiffer and can in fact change your scope angulation once you actually pass the needle down, and therefore probably better to reserve for lesions in which your scope has a straighter position to start with. It's also important to remember you don't want to set yourself up in the most ideal position and then pass your needle, because as I mentioned, if you're using a larger needle, oftentimes you have to go out of position in order to actually extend the needle out, and then you lose that visualization, excuse me. So my preference or practice My go-to needle is a 22 gauge needle. I use this for almost all pancreas lesions, except again, maybe the Uncinate process, I might switch to a 25 gauge needle. For lymph nodes, I use a 25 gauge needle in order to avoid very bloody aspirates, as this is associated with the least amount of blood. For cystic lesions, I use a 22 gauge unless I'm planning an adjunctive sampling procedure like use of Moray biopsy forceps or visualization with Cellvizio. And for some mucosal tumors, again, I typically only biopsy larger lesions. I don't biopsy small lesions. And for this, I can use a 22 or a 19 gauge needle. What about core biopsy needles? Well, the question here is really, are you trying to achieve larger samples, or are you actually trying to achieve a structural core? If we're just looking for more tissue, there's actually very variable results comparing FNA versus FNB. I was part of a randomized controlled trial led by Satish Nagula that compared these two, and there was no difference in diagnostic yield, regardless of whether or not you had on-site cytology or the type of lesion that you were sampling. But there are different results in the literature. So there's other studies that do show a high diagnostic yield and cellularity with FNB. I think was a very useful study that suggested that it may have to do with whether or not you do have access to on-site cytology, that if you do have access, there's really no difference between the two needles, but if you do not, then fewer passes are needed with FNB to achieve adequate tissue. If you need an actual structural core, such as for immunohistochemical staining or genetic testing, or most commonly a liver biopsy in which you want a minimum number of portal tracks, then an dedicated FNB needle is certainly recommended. And so for my practice, I actually use FNB now for all solid lesions. We have a very oncology-driven practice. They do have a lot of protocols now that are requiring specific core biopsies, and they ask for extra tissue for banking and genetic testing. For FNAs, use that needle for cystic lesions. The one thing about the tip of the biopsy needle is that it does have multiple points of access and cutting, and this can cause some degree of shearing, whether it's a cyst wall or vessels, and there have been reports of bleeding, particularly with liver biopsies. So I use FNA for highly vascular lesions or lymph nodes. What about the techniques of EOS FNA? There's a couple of different prescribed techniques. There's the dry suction technique, which is basically passing the needle with the stylet down, putting it into the lesion itself, taking the stylet out, and then applying a negative pressure vacuum suction. All of the needles come with their own proprietary syringes for this purpose. There's also the wet suction hybrid wet suction method. This is where the needle is pre-filled with saline, passed down through the scope and into the lesion. And then for the wet suction technique, a fluid-filled syringe is used, and then the negative pressure is used for the suction. In the hybrid wet suction technique, it's the same technique, but the suction catheter does not have saline in it. So it's a dry negative pressure suction technique. And then finally, the capillary or slow pull technique is where the stylet is left in place. The needle is passed into the lesion, and then the stylet is slowly pulled out by the assistant as the endoscopist passes the needle back and forth through the lesion. Again, in the literature, there's no significant differences in accuracy or rate of achieving an adequate sample, but some suggestion that the slow pull method in larger lesions might be more favorable. For my preference or practice, again, my go-to method is the slow pull method. If I am, after one or two passes, not achieving enough cellularity, I will switch, and it's usually to a dry suction method. In general, I avoid suction for lymph nodes, as again, it's associated with a slightly more bloody sample. There's other techniques as well to try to achieve increased cellularity. For example, the fanning technique Here, you're basically trying to sample different parts of the lesion. So you can put the needle first into the center of the lesion, bring it back towards the periphery, move your big wheel away, then advance the needle. So this, when you move your big wheel away, it actually moves the lesion in this direction. And then bring it back to the periphery, depress your elevator, which actually physically moves the needle itself down to the bottom of the periphery, and you advance the needle into the lesion again. You want to avoid anechoic or necrotic areas, although it's tempting to go into the very center of the lesion, as this will decrease your cellularity. And if you have a cluster of nodes, for example, smaller nodes, you can actually target the largest, but then even advance the needle into contiguous nodes, as you're not at risk of, for example, puncturing a capsule. So this is a kind of an example of fanning technique. Here we go into the center of the lesion. This is actually a liver lesion, liver met, and take one or two throws of the needle, or a couple throws of the needle. Then we'll move that big wheel away, and you'll see in a moment that the lesion will move a little bit in this direction, and the needle will sort of hit the periphery over here. And there, right there is where you see the big wheel away, and then you use the elevator and it depresses the needle and you go into the other side of the lesion. Sometimes we run into a situation of having poorly defined lesions, or we have repeat procedures for patients who don't have diagnostic tissue. In these situations, I like to use certain landmarks, for example, targeting tissue around the area of a change in caliber of the duct, or if a patient who's had a previous ERCP, for example, and has an indwelling stent, I actually target the stent itself and maybe even hit the stent with the needle, with the idea that the stent, it's going through the actual lesion, even if you can't clearly see the tissue. Or hitting the site of anastomosis in patients who've had prior surgery, such as a Whipple or distal pancreatectomy. We do have issues with sometimes lesions in the pancreas head or the Uncinet's process, again, because of angulation of the scope or torque required. And in these situations, you really want to position the endoscope as straight as possible. Sometimes this means advancing beyond the lesion, reducing the scope, and then finding a more favorable position. Sometimes lesions can be too hard or fibrotic. There's two methods used here. The one that I call lock and jab, where you basically measure the lesion diameter, you measure the distance from the mucosa, you lock the needle, at that distance, and then you very forcefully jab down or stab the needle down. You do want to be aware of your own strength, and you want to make sure the lock is very tightly locked so you don't advance further than needed. Or the plant and push, and I thank Amol for this picture where you put the tip of the needle just superficially into the mucosa and then actually push the scope itself forward, which mechanically pushes the needle into a fibrotic type of lesion. Lesions can be soft or sticky sometimes as well. And again, here I use the scope itself to manage by, for example, putting the needle all the way into the end of the lesion and then big wheeling away and allowing that to pull the needle back slowly and avoid trying to come out of the lesion. Or lesions that have overlying vessels. I'll show you the two-step procedure. I do not go through vessels in order to access lesions behind them. I think that can be quite dangerous. This is the two-step FNA, where the needle you place with the first jab just below the surface of the mucosa into the tissue, and then you can redirect the needle either into small lesions like you see here, or for example, when you are trying to avoid overlying vessels, you can place it superficially into the mucosa. If you press your elevator, this physically moves the vessel back, and then you can continue to advance your needle into the lesion. I'll skip this video because it's, well, actually, let me just play it for you. Here you can see there's a little difficulty in really advancing the needle further into the tissue. So once you get it just inside the mucosa, then you are going to do a little bit of the jab and in the two-step procedure, and then advance further and take your sample. Rapid on-site cytology is a very useful resource if you have it and it has been associated with fewer non-diagnostic samples, and there's excellent correlation with final pathology. and very important to communicate with your pathologist, provide them clinical background, and important to tell them the location of the lesion and your access, for example, transduodenal versus transgastric, so that they can it helps interpret some of the cells that they may see to determine if there's contamination. For the number of passes also depends on your pathology, whether you have on-site pathology available. If you do, you should let them guide you as to how many more passes you may need. Sometimes they feel confident but want extra passes directly into formalin in order to perform extra staining. If they're not available, I do a minimum of about 6 passes for pancreatic lesions, but fewer for lymph nodes and vessels, liver lesions, maybe 3 or 4. So in summary, here's kind of my approach. I do use ROSE when available, which I have available to me during the week, almost during the day. Again, I find the straightest approach. This may require advancing and reducing to determine that approach. For body tail lesions, my go-to needle is a 22 gauge, occasionally the 19 gauge in the stomach. For tail lesions in the head, a 22, and the uncinate 22 also, but sometimes a 25. For solid lesions, I use a FNB needle with a slow pull technique and switch my method if it's an acellular sample after 1 or 2 passes. For cystic lesions, a 22 FNA. I suction the fluid. I then throw a few throws after the cyst collapse into the tissue itself to try to get some tissue from the wall and then withdraw the needle. For lymph nodes, a 25 gauge with a slow pull technique, and switch only if I have an acellular sample. And for liver biopsies or pancreas biopsies in which we're trying to gain structural information, I use a 19 or 22 FNB needle with the slow pull method. And again, change my method if it's a acellular sample. And here I only do 2 throws or actuations for these biopsies. I just really want to acknowledge Amol and thank him for a lot of the content of this talk, and hopefully get a chance to take a look at his book. And thank you for your attention.
Thank you, Dr. Sethi. It was a really wonderful presentation and very practical tips discussed as well. There is a question among the participants from Dr. Nikhil, and he's asking for the tips for the FNA or the uncinate process mass. How do we take FNA from the masses in the uncinate process or the pancreas?
Yeah, so that's a great question, and oftentimes very difficult not only to take the sample, but actually to really get a good view of the lesion. So again, I may advance beyond and then reduce the scope to try to get as straight position as possible, and then use a 25 gauge. I didn't mention differences between needle brands, but if anyone has access to, for example, the more flexible needle by Boston, or even the Olympus needle, which uses a different mechanism. It's a spiral, it has a sort of spiral mechanism. It allows the needle to actually advance a little bit more easily in those very torqued positions. And then I use also the plant and push technique, where you're physically using the scope to advance your needle into the lesion, as opposed to trying to transmit the force of the needle itself through a very torqued scope.
Okay.
Also, do you use skillet, or you have abandoned the use of skillet while taking FNAs?
No, I keep the stylet in, and then I use the slow pull technique, where my assistant is slowly pulling the needle out as I'm actually taking moving the needle back and forth in the lesion.
And will it make easier to do FNA if the skillet is not there, especially for the uncinate process mass lesion?
Not in my experience, but again, everyone has a different practice, and if I'm doing that after 2 passes and I'm really not getting good tissue, then I'll take the stylet out and use a different technique, such as the suction technique.
Okay. Thanks, Amrita. I think wonderful talk. Just one quick question to you.
Sure.
You know, you're doing a lymph node FNA and your first pass is bloody. What would you do?
Yeah, I would change my technique. So
You just aspirate lymph node. It's a firm to soft to firm lymph node, and you put in a needle and you just aspirate almost blood. What would you do?
So if the first one is blood, yeah. So that's why I start with my my slow pull technique, because it tends to be less bloody in my opinion. I would try to avoid the tract that I've created with the prior lesions. So first of all, I would switch my method. And again, because I start with slow pull, I try to avoid suction in the beginning, which I think causes a bloodier aspirate. And then I would try the fanning technique and avoid as much as possible going back into the same tract. So really just one pass forward, change my position. And so that way I can avoid not only not getting any cells, because, you know, the needles really push away the tissue in the lymph nodes. It's such soft tissue in most situations, and going to the periphery as much as possible. I don't know, I'm sure you have techniques as well. You wrote the book.
No, that's always a challenge. Sometimes, even when you don't use suction, sometimes you may get a bloody sample. Rajesh, I know we are running short of time. There's one question by Dr. Nikhil. Can we take that? Gastric body SEL, subepithelial lesion. The needle bounces back. How do you handle that, Amrita? Meaning, subepithelial lesions in the stomach. Usually the needle will bounce back, and then it's very tricky to get the needle inside the lesion.
Yeah, so that's where I use a combination of the two-step technique as well as that lock and jab. It can be a little distressing to watch actually, but if you put the needle, you tent the mucosa, you depress the needle with your elevator, so you actually see the needle deform the mucosa tip sort of downward, and then I lock, again, I take a pre-measurement, but I unlock the needle lock and then lock it at a fixed amount. So for example, sometimes even 4 centimeters, 3 centimeters, depending on the size of your lesion. I lock it tightly, and then I keep my big wheel towards me so that it's hugging the mucosa, and then I very strongly punch down the needle. It can look very concerning, and again, you want to make sure that it's tightly locked, but that oftentimes helps me get into the lesion in the stomach itself, which can have a thick mucosa and be very fibrotic.
Thank you, thank you. So Chitranshu, Deepak, any further questions, or should we wrap up?
I think
we can wrap up to stay on the time.
Right.
Because till now we are absolutely on time. This session we are 3 minutes delayed.
Right.
So if we can start the next proceeding.
I think so. Let me just thank Moen and Amrita for their wonderful talks, and it was great being here, Rajesh. And also I would like to thank Deepak and Chitranshu for co-chairing this session with me. And over to you, Rajesh. I'm going to shut myself up so that you can take it forward.
So thank you, Chairperson, and thank you, Speaker.